Okay, let's go ahead and get started. Welcome to Preparing for STEMI Amid COVID-19, a Southwest region discussion. I'm going to pause there and just do a sound check. Are you able to hear me, Audrey or Kristen? Or okay, great. Thank you, Laura. So thank you for taking the time to join us today. I am Lonnie Den, and I serve as Regional Vice President of Quality and Systems Improvement and Mission Lifeline for the Southwest region of the American Heart Association. We've had significant response to this webinar. About 200 of you registered to participate. We know that your time now and more than ever is precious, and we hope to use it today to facilitate conversation and to discuss barriers that you've encountered or barriers that you anticipate in the current environment, and share what you're doing to continue to provide the best care possible for your heart attack patients. I want to thank you for your selfless leadership and your commitment to providing quality care during these unprecedented times. Thank you all so much for all that you are doing for our patients across our region. You've been placed on mute as you join the call today, and when we pause to take questions or comments verbally, you will be able to come off mute on your phone if you've joined that way by pressing *6. And then when you're done talking, you can mute yourself again by pressing *6 again. It's *6, not #6. If you've joined with the audio with your computer, you should see a microphone icon at the bottom of your screen that will take you on and off mute. You may also use the chat box for comments and questions. Kristen Waller, QSI Director for the state of Arkansas, is going to help us monitor the chat box, and I will do so as well, and we'll share your comments. With so many people joining us today, please take care to stay on mute when you're not talking. Please remember to not put us on hold so that we aren't delayed with hospital messaging or music. And with so many people on the line, we expect that there will be times that we may be unintentionally interrupting one another, and there might be moments of awkward silences. With that in mind, we know that will happen. Please don't be shy about coming off mute to contribute to the discussion. Audrey Bell is providing our webinar support. Please contact her for any technical issues that you might be having. Her email is at the bottom of most of the slides in the deck. When we refer to the Southwest region of the American Heart Association, we are referencing the region that you now see in red. That's made up of the states of Arkansas, Colorado, New Mexico, Oklahoma, Texas, and Wyoming, as that's where most of us live and work. This data is from the New York Times yesterday, and it shows a significant difference from region to region. So we come together today in hopes that we can all share what we know, what we have heard from other areas of the country that have had higher incidence, and plan together for the peak that has fluctuating projections, but predicted to take place in our area anytime between next week and sometime in May. We hope that this will be an interactive and full hour. All of your ideas and challenges are important, and we know that you have significant expertise to share. If there is something that we don't get to discuss today and there is interest, we are open to convening again. Just let us know your thoughts in the chat box. So this slide, this is a visual of how rapidly the situation is changing. This is the slide that I would have used just a couple of days ago. These are the numbers from earlier this week, from Monday. It's a little frightening to see the number of confirmed cases increasing in our area at such a rapid rate. So this is the slides that I was going to use. This is the slides that that I inserted yesterday. So these are the numbers as of yesterday. So just in our Southwest region, we've gone from just under 15,000 confirmed cases to 19,000. So it's on the rise for sure in our area. So I'd like to present around 10 slides that contain a few updates from the American Heart Association. And then I will turn the call over to Dr. Wozniak and Dr. Henry. The updates are not a comprehensive look at all the things that are going on in our organization and things that our organization is doing. It's a small subset that is most appropriate for our conversation today. I will go quickly, but the slides will be shared at the completion of the call, so you will have all the links, the emails, and the information. So with your critical work in mind, we're making some adjustments to adapt to the current environment. For those of you who participate in Get With the Guidelines coronary artery disease, the data submission deadline to complete 2019 patient records has been extended. We know that most of you have completed your data entry, but if you have not done so, the deadline has been extended to April 30th. And if you need additional time after April 30th, we will work with you. Just reach out to me or to your local QSI director. We will continue to evaluate additional appropriate changes for recognition in 2020 and 2021 that allow for the adjustments that you are all making. For those of you who are participating in Mission Lifeline EMS, the deadline for applications for 2020 EMS recognition has been extended to May 29th. And studies have reported a link between COVID-19 and pre-existing cardiovascular conditions. Understanding this disease and its impact on patients with cardiovascular disease is critical. So to respond to this, we are updating Get With the Guidelines coronary artery disease to collect important COVID-19 data elements. We've added data elements related to infectious disease, and we will apply non-systemic to appropriate measures as exceptions. The coding instructions for the data element patient referral to cardiac rehab has tested for extenuating circumstances. Adjustments to 2021 Mission Lifeline EMS recognition will be made to allow for COVID-19 non-system reason for delay to applicable measures. Adjustments to 2021 Mission Lifeline recognition for our STEMI referring hospitals who typically transfer their patients out will be made to allow for non-system reason for delay due to COVID-19. And American Heart Association and the Joint Commission have extended certification deadlines for our co-branded advanced cardiac certifications. So for those of you who have a comprehensive cardiac center certification, primary heart attack center certification, acute attack center certification, or advanced certification in heart failure. We have committed $2.5 million to fund fast-tracked heart and brain-focused scientific research of COVID-19. Late last week, the AHA announced that we will be launching a new registry, the COVID-19 Cardiovascular Disease Registry, powered by Get With the Guidelines. It's expected to go live in early May, early next month. The registry was created, The registry was created to better understand clinical treatment patterns and variations, including the collection of biomarkers and cardiovascular outcomes in hospitalized COVID-19 patients across the nation. The registry will focus on real-time, granular data from acute care hospitals to better help clinicians and researchers understand and provide feedback to healthcare organizations on how to best treat COVID-19 patients. Facilities who enroll in the registry should have strong protocols in place for collecting cardiac labs and have the capacity to enter all hospitalized COVID-19 patients. At this time, there's no fee associated with participation, And if you believe that your site is a candidate for this registry, please reach out to Stephanie Chapman at heart.org, and her email address is on the slide. We recognize that CPR training in this environment may be challenging. Because of this, all expiring provider and instructor CPR cards have been given a 120-day extension, and we'll continue to evaluate appropriate extensions. If your facility is doing traditional instructor-led CPR training and your training department is struggling, our QI Partners has a free solution that will help you maintain credentials and skills during this time. So please encourage your training center, if this is the case, your training center partners to contact Allie Bateman at heart.org if they are interested. And then we have launched multiple sites on heart.org to help you navigate COVID-19. There are curated resources, a collection of concise but detailed information for healthcare providers, and a newsroom. The resource I want to highlight is hospitalnetwork.heart.org. It can be found when you follow the Healthcare Professional Forum link that's on this slide. This will be an appropriate place to share your protocols and your policies that your facilities have developed for heart attack and stroke patients in response to COVID-19. And we know that most of you are reporting significant declines in your STEMI volumes since the pandemic started. We know with the stay-at-home orders enacted all over the country that patients are hesitating to seek life-saving treatment for heart attack and stroke. So to help, the American Heart Association has developed materials for you to use in any way you see fit, encouraging patients to call 911 if they're experiencing symptoms of heart attack or stroke. Please share the PSAs and information broadly through all of your circles of influence in any way that you see fit. And I'm hoping to play just one sample PSA. Let's see if we can get this to work. Hopefully that came across okay. It's just the examples of the materials that are available for you to use at will. At this time, I am so very pleased to introduce our host and our guest for the remainder of the call. Although both of their resumes are very long and very impressive, I will just share with you that both Dr. Robert Wozniak and Dr. Tim Henry are interventional cardiologists, and they have been STEMI Systems of Care champions and American Heart Association Mission Lifeline leaders and volunteers for many, many years. Thank you both so much for being with us today. And we'll turn it over to Dr. Henry to provide a summary of a publication that was released last month that I know many of you are using as a resource for how to keep your cath team safe and your cath labs humming during the pandemic. So, Dr. Henry?
Yeah, hi. Do you want me to start, Lonnie?
That'd be great. Yep.
Okay. Well, welcome everybody in this really crazy time. And just as a short background, and I have been involved in Mission Lifeline and am now on the Get With the Guidelines STEMI Systems Committee on a national level. I'm also involved in the Society of Coronary Angiography Intervention as currently in Vice President, and I'm also on the ACC Interventional Council. So it gives me an opportunity to coordinate between, I think, the societies, which I think right now is critically important because our goal is to provide guidance that is relatively uniform. And so I'll try to do that. I would like to let people know that there is already a published in JACC a cardiac cath lab document that I think that is of interest from ACC SCI, and then next week there will be a new specific guideline in JACC online from the American College of Emergency Physicians, SCI, and ACC about myocardial infarction. And then finally, there's a document from the Mission Lifeline in terms of regional STEMI systems, which should be available soon. And those are really I think well done, and will hopefully provide some good guidance for people. That being said, based on that, what I'd like to do is just to sort of highlight what I think are some really important issues regarding this really crisis. And so COVID-19 is an unusual disease in the sense that there is a high percentage of asymptomatic or minimally symptomatic patients. As our testing has really been a little bit suboptimal and is increasing, the exact number is unclear, but it appears that 35 to 50% of patients are really asymptomatic, and yet at the same time can be infective. So the time period that patients can be infected is really quite long. And so those two things, the fact that there's asymptomatic carriers and that patients are infected for a long time, allows this to spread rapidly. And then number two, it's a population that has really zero previous immunity. So I think that's one challenge. On the other side, you have this small percentage of people that have very severe mortality, so that are intubated with severe viral pneumonias. There is what's called a cytokine crisis, which when patients are getting better, they actually can die very quickly of a shock-like syndrome. And then you have increase in both myocarditis and arrhythmias. So you have this, on one hand, very asymptomatic population, on the other hand, a very sick population. What we know for sure is that patients with underlying cardiovascular disease are clearly at increased risk of having severe complications, and that includes diabetes, hypertension, and any cardiovascular disease. It's also true that elderly and in particular populations, but the diabetics and obesity are very severe risk factors. So at the same time, COVID itself has increased cardiovascular effects. So it appears that 25 to 30% of patients, when they're admitted to the hospital, will have an elevated troponin. And it's very clear that patients with an elevated troponin are at particularly high risk. So I think those are some really important things regarding COVID itself that people need to be aware of. Then I think from a standpoint of STEMI systems, there are really a number of things that have been recognized, talked a lot about on social media, and are now becoming clear with data. And that is what's been happened all across the United States is that we've seen a decrease in STEMI activations, and many of you might have known that. There's actually going to be a paper online today that I'm a part of from 9 large regional STEMI systems that show that there's about a 40% reduction in STEMI activations. And that was true in all 9 regional STEMI systems. So it's a consistent issue across the country. The second thing that's been clear is why is there a decreased activations? What you would typically expect when you have an infectious, like a pandemic like this, or even an epidemic, what happens in the flu season, for example, there's actually increase in STEMI activations because the virus itself can cause plaque rupture because of increasing stressful situations which increase plaque rupture. It also, in this situation, we have increasing STEMI mimics with increasing myocarditis that has ST elevation, increasing stress cardiomyopathy, which can present with ST elevation. So we would actually have anticipated that there would be an increase in the number of STEMI activations. So why is that? Well, I think the second thing that's becoming increasingly clear is that there's increase in delayed presentations. So we've seen a rise in the number of patients presenting in complications of myocardial infarction, such as ruptured papillary muscles or ventricular septal defects or LV thrombus. You know, all of these are diseases that with primary PCI and rapid treatment, we had almost completely cured. So it's a really, I think, in a sense, disheartening to see, this happening. And clearly, what we're seeing right now is an unintended crisis consequences that, at times the cure, which is this intense social distancing and decreasing elective procedures and really encouraging patients not to go to the hospital, can actually be, cause morbidity and mortality. So I think to that end, that's a really, really important thing that we can do. Those of you on the phone that you can do is that you can encourage patients who have chest pain, who have signs of acute myocardial infarction, to go to the hospital, just like they would normally do. Call 911 and go to the hospital. Second of all, what we need to do is for healthcare providers is it's really important to remember, yes, there's COVID out there, but there's also patients with heart failure and heart attacks, and that we need to continue with the liberal use of EKGs and evaluate patients just like we would normally do. Now, I will say that one of the other challenges of this is that there's dramatic variation in the prevalence of the disease across the United States right now. So you have a situation with New York and New Jersey where there's very high prevalence of the disease of infected patients, and the whole hospital systems are overwhelmed. Likewise, Detroit is a place, Indiana is a highlight, New Orleans is, but in general, most of the places on this one, it's actually been the opposite, where there's a relatively low prevalence of the disease. And I suspect many of your hospitals are actually empty, and it's the other side of this severe social distancing and things that are affecting you in different ways. So I think those are kind of some key points, and I will stop there, and I'm more than happy to answer questions. But I would say that this is really unprecedented challenge that we're facing, and I sympathize with you because I know all of you are trying to develop algorithms that work, and the last thing I'll end is it's absolutely essential that everyone use personal protective equipment and be safe, because what we do know is because of the infectious properties that I talked about, healthcare workers in particular are at particular risk. And what we know in Europe and in the United States already is that EMS personnel, emergency department personnel, and ICU and cardiac cath lab personnel are all at increased risk of developing COVID, which has implications not only from a health standpoint, but from a healthcare availability standpoint. So it's critically important that everyone's prepared for this in the use of PPE and have it available in your hospital, etc. So I think I'll stop there, Bob. Is that and I'm happy to answer any more questions as well.
Well, thank you, Tim. That was awesome, a great way to kick us off here. And I'm always learning from your experiences. As many of us understand in our past experiences building our STEMI systems of care, we learned so much from each other and how to do things better. Every time I've gone to those meetings, I've left smarter. And I feel like we're having a STEMI meeting here of 2020. One thing, Tim, I recall way back when I probably even got some order sets that you and Barb developed back in your Minneapolis days. So again, the importance of how we learn from each other and sharing information to improve someone's ability to deliver care, particularly at this time. And I wanted to thank every one of you for putting yourself on the front lines and doing what you're doing and leading your teams by being on this call. So with that said, I wanted to divide the remaining 30 to 35 minutes up into a sort of a pre-hospital phase, a hospital phase, and a post-hospital phase, and then save about 5 minutes for any final comments. So I'm going to try to keep us on track, but this is everyone's conference. We want you to get as much out of it. Don't assume that because you're doing it, everybody else is doing it. If you feel like something you're doing is particularly helpful, please speak up, because I'll be writing those great ideas down myself. So with that said, for the pre-hospital phases, as Tim had talked about, there's a lot of stuff going on that people are staying at home. And we heard the AHA is rising to that opportunity to educate the public here. And so the question I have is anyone actually using something now to educate the public? If so, how are you using it? And then do you see a use, or how will you use some of this information that the American Heart Association is providing for us? Well, Tim, let me ask you a question as far as, do you think that some of this information, how would you try to get this out to the public in your system?
Sorry, can you hear me? I must have been on mute. Sorry about that. Can you hear me all okay?
Yes, I hear you.
Yeah, so first of all, I think the American Heart Association information is critically important because it's, from my perspective, it's the most targeted for patients, and I think and regional STEMI systems. And I think this is really important because we've done a really good job of scaring patients. Listen, it's critically important that they understand the risk, and I spend time every day talking with my patients, in particular those who are elderly or those with cardiovascular disease, how important it is to be careful and really do social distancing. On the other hand, we have to at the same time emphasize that chest pain, shortness of breath, swelling in your feet, syncope, that these are things that can be life-threatening emergencies, and that when you have them, you need to go to you need to call your physician, and you need to go to your local hospital. And I would tell you that I think the majority of hospitals around are working very hard to provide COVID positive areas of the hospital in contrast with COVID negative areas of the hospital. Whereas testing has been a little slow to get up there, what's going to happen and is happening already more frequently across the United States is the availability of rapid testing. I really hope that within 2 weeks, that almost every hospital system in the country has this available, where if you have a patient that's at risk, we'll be able to know the result within 10 to 15 minutes in the emergency department, and that would totally change our perspective. But I think that the AHA materials have been excellent for both public awareness as well as awareness for the regional, for the healthcare workers as part of regional STEMI systems.
Hello, this is Tiffany Weaver here in Austin, Texas, St. David's, North Austin. I was just going to mention that I did get a copy of the PSAs and everything that Lonnie mentioned, so I forwarded them onto our marketing director here at the local level to see if there's something our hospital system, or at least us at North Austin, can post on social media and get the word out. Still call 911. It doesn't have to be COVID symptoms that you're having. Other things occur that need emergency attention.
I appreciate that. And now moving on to what has EMS been doing anything different in your system that you found is particularly useful to give us a head start on that patient more than we would usually have?
So from my perspective, you know, in Ohio, we actually are probably similar to where most of yours are. We had a very aggressive social distancing from the governor, and fortunately, and we probably at this point in time in the hospital have approximately 15 to 20 patients that are either on a ventilator or on VV ECMO, and that has stayed relatively stable for the last 2 weeks. So maybe gradually, you know, 1 or 2 per day increase, but then also we have patients that are getting off the ventilator and are going home. And so we've not had, we're certainly not anywhere close to overwhelmed. And we have probably the most of anybody in the region. So, and this is the way it should be, is that we're prepared. We have specific units that with negative pressure that are designed for COVID patients. We've switched one of our cath labs to be negative pressure. We have adequate PPE, and anybody that goes to the cath lab or anyone in the taking care of the patients in the unit are very careful about using PPE. So those are, I think, some of the things that we've done. We really have algorithms that we want everyone to stop. I think a couple key things, rather than pre-hospital identification and go straight to the cath lab, we have instituted that everyone stops in the emergency department and that we do a very quick evaluation, which includes a chest x-ray or a point of care ultrasound. So this will depend on what's available at your hospital or not. There's some people that are doing point of care ultrasound where you look at both LV function and you can also evaluate the lungs. And the people that are good at that, it can be very valuable to detect not only left ventricular dysfunction, but the pulmonary effects of COVID. So then with that rapid evaluation, we also then, with an EKG, it's very important to take into the combination of symptoms, the probability that the patient might have active COVID-19 based on their symptoms, and the EKG findings. And so, for an example, a patient that might have more dyspnea and cough and might have more diffuse ST elevation, you know, more consistent with myocarditis, that patient, and if we then did a handheld echo and shows that it's global decreased function, we might not even take that patient in the cath lab. On the other hand, the patient who had classic chest pain, has a localizing ST elevation on the EKG and a wall motion abnormality, that patient would go for primary PCI just as we expect. One thing I will say, there's a lot of discussion about lytic therapy. And I think from a lytic therapy standpoint, the current recommendations are that lytics should be really reserved, just like we always use lytics, and that is for patients who are expected to delay greater than 120 minutes. And one reason we have brought that up, and this whole discussion came from China, where there was this recommendation to use lytic therapy. But I think many people in the United States feel that, number one, there's an increase of STEMI mimics. So you have myocarditis or you have stress cardiomyopathy, and then you give that patient lytics, you give not only the risk of bleeding, but then they still have ST elevation because it's not effective, and so they end up going to the cath lab anyway. So we still believe that primary PCI should be the preferred choice, but that with some thoughtful consideration based on the symptoms, EKG, and whether or not the patient might be positive. And if you have rapid testing, even better. And if you don't have rapid testing now, certainly it should be available in the next 2 weeks across almost the whole United States. Is that helpful?
I'm gonna finish up in the pre-hospital phase, and I'm gonna come back to you, Tim, and because I know that lytics is a very hot topic and concern, and I appreciate you touching upon that. And I'm gonna come back to you about converting a positive pressure ventilation into a negative one. We're really gonna tax you there. But one of my final question for the pre-hospital phase is that as far as communication with the hospital, it's so important. And as I was preparing for this, I ran across something that we had looked upon here about 5 years ago, a company called Pulsara. And some of you may already use that. And it basically is a streamlined way of EMS communicating with the whole healthcare team. And so the good news is it's free during this COVID time. And our Austin EMS, Austin Travis County EMS, is already using that for their providers to work with sort of a central command in understanding what degree of PPE to use for each call that they are encountering. So I like the word free. I think it's a very nice system, and I would say that it may be worth looking into in your current system to see if it will optimize the communication from pre-hospital to the hospital phase. I'm going to move now into the hospital. So now we're in the emergency department, and Tim covered a couple of things that we look for all the way up to doing a point of care ultrasound here. And I'm going to open it up to everyone as far as does anyone have anything else they want to add as far as distinguishing between a true STEMI versus a STEMI mimic, which from my estimation, it looks like, Tim, and correct me if I'm wrong, it's about 10 to 15% that we would expect STEMI mimics, or am I underestimating that?
So, you know, we don't know the answer to that yet. We have a ongoing COVID registry, and so if anybody out there wants to be part of that or has had COVID patients with ST elevation, we'd love to have you join. You can contact me by email. But what I think it actually is going to be higher. I think the number of STEMI mimics is going to be more like 30 to 40% just based on our initial analysis, especially in high COVID areas. So like in New York City and New Jersey right now, I think that we're seeing 30 to 40% of the patients that go to the cath lab that have normal coronaries.
Does anyone want to comment about their experiences in STEMI mimics in their area? Does anyone have anything else they want to add regarding distinguishing between a true STEMI, that the garden variety one that we would see with obstruction of the coronary artery as well, versus a STEMI mimic? Tim mentioned the point of care ultrasound. How about EKGs? Is there anything on an EKG that someone has found that may be helpful to distinguish that? For instance, a diffuse ST segment elevation that would not necessarily follow a specific vascular pattern versus a more localized one, say an inferior infarct. And as you said, Tim, a lot of it is we're still learning, but this is why we're trying to learn from each other here.
And before you move on, Dr. Wozniak, there's a couple of comments in the chat box related to the pre-hospital environment. We have a note from Kim that says that is asking, has COVID-19 affected the transport of anyone's STEMI patients directly to the cath lab? We have had some issues and are currently back to receiving all patients in our ED to ensure vigorous screening with physician communication to determine appropriate treatment. And then
let's just answer that right now.
Yeah. Yeah.
I'm going to say that it certainly in our system has caused us to slow down and really think about this from the balance between staff exposure versus patient benefit. And so we have not been bypassing the emergency. We're using that time to evaluate, to sort of subsequently evaluate the patient for COVID, as Tim has mentioned. And I would just pause here and ask, wait for anyone else has any other thoughts on that. Okay, Lonnie, what was your other question that we should focus on?
Yeah, Marty's is telling us that the ED is screening all of their patients, and she's heard from at least one of their cardiologists that he's going down to the ED to see the patient first. And then Chelsea is saying the Heart Hospital in Plano has suspended ED bypass.
So as far as a cardiologist going to see the patient in the emergency department, again, the way I think of this, any way I could eliminate somebody coming in contact with a potentially infected patient, then we should make that effort. That's just my own experience, and I think that's what we're practicing here. Anyone else have any other thoughts on this? I know there's some cardiologists on this call.
Sharif Aleem. I'm an interventional cardiologist in Albuquerque, and I totally agree. We've been telling them, make sure you stop, and then the key is having EMS at least do an initial screen. I think sometimes they get focused on the EKG and not necessarily getting all the key symptoms, and then all that extra time that then you have to reassess in the ED to identify somebody's concern or whether the likelihood of COVID is high. And then just as a follow-up, I mean, what we haven't done yet, but what we've talked about doing is for people that have a high likelihood of good, reperfusion with lytics, and if it's an inferior MI within, 3 hours of symptom onset, they're hemodynamically stable, whether that should be the primary mode of reperfusion in a select group of STEMI patients.
Yeah, I was going to have that debate with Tim here because I think that there are, as far as if we feel confident that this is a STEMI, a true STEMI, based on maybe our point of care ultrasound, EKG, and the story, and lack of symptoms, I guess we could go right to the cath lab, but if they're still concerned about their COVID situation, the mortality benefit for lytics and PCI, it seems like would be comparable. And so I share your thoughts on that, and I think that there are some ideal patients that could benefit from that. I'm going to throw this. Is there somebody that wants to chime just to make a comment? I'll stop. Tim, I'm going to throw this question out because I think it's kind of a hard question. It's an uncomfortable one for me to ask. But are there patients that the mortality you alluded to are sickest, oldest, have the ones the highest mortality? Is there a situation that you could find yourself that we go right to sort of conservative or supportive care on a patient, and we're so patient focused and let's go fast, but sometimes would you see that we could encounter a situation where we just say the chances of survival are so low that we're not going to do anything other than supportive measures?
Yeah, this is so I will say that the two topics that are most challenging and most discussed are, number one, the lytic topic, and then number two, the issue of futility. So let me just go back to the lytic one first to start with. after a lot of consideration and a lot of discussion, and I can't really emphasize how much, based on places that both are very busy and very not, I think that we came as this writing committee together that primary PCI should still be the preferred choice. And I'll tell you why. So let's take that inferior infarct with that it's relatively low risk. Another really important point in this area in COVID is if you do primary PCI and you get a good result, about 50% of your STEMI patients are low risk. Those patients do not need to go to the CCU and can be discharged in less than 48 hours. So I think most of us would argue that in that patient, doing primary PCI would keep them out of the intensive care and get them home faster than doing the lytic approach. And so I think for many reasons, we believe that PCI should be the primary choice and that lytics should be reserved for those patients who are at a non-PCI hospital and are expected to have a delay greater than 120 minutes. Now, the second one is much more difficult, and that is, and I can tell you there's a lot of conflicting information. So out there, for the patient with cardiogenic shock who is COVID positive, there's some evidence or some case reports that VA ECMO or Impellas are not very successful and that the patients do poorly. There's also been some conflicting information about VV ECMO for the patient who's not oxygenating well. And this all depends on what your availability of ECMO is and your availability of mechanical support. But I would say it is another really important point is to remember that even though a patient might be suspected COVID, you don't know if they're positive or not. And patients who have, I'll give you an example from one of our physicians. A 28-year-old postpartum patient came in with cardiogenic shock, and most of the symptoms were related to a cough and a URI. And so there was a lot of talk about was it COVID or not COVID. And anyway, the patient ended up getting VA ECMO, and it turns out she was COVID negative, and this is a patient who had either a postpartum or a viable cardiomyopathy who subsequently recovered and did well. Well, imagine if we would have not treated that person. And so I think we have to we should, number one, be treating people the way that we would normally treat them. I think that's a really important take-home point, with the caveat that we have to be thoughtful and think about it and be careful from a standpoint of PPE equipment. Does that help, Bob?
That helps, and I think that that is good at postpartum. But I'm even thinking of you're 85, unfortunately, and you've come down with COVID, and you're maybe having STEMI, maybe not. And so, and now again, I have to weigh the risk of staph exposure and those things versus what are the chances of survival. So it's a very controversial topic that, again, this is just my opinion, nothing to do with this, I'm sure, the Heart Association, but it's something that's real life and it's hard to talk about. And I appreciate you, I mean, and your lytic comments are right on. I appreciate that. I'm going to.
Here's what I would.
Go ahead.
Go ahead.
Oh, just some comments in the chat box, and you're right, lytics. It's a hot topic. We had some folks typing in that one of their regional facilities haven't been able to get tenecteplase. Is there a shortage? Also, some of the facilities that are really writing into the protocols that that if the patient is a positive COVID patient, that the system would move to use lytics. There's a couple more in here. We're also considering lytics over primary PCI for stable STEMI patients with COVID. Our pharmacy states we cannot get any more tenecteplase. Does anyone use alteplase?
we have that in place. So I think the lytics are comparable as their effectiveness. Obviously, different dosing, and you should know what you have in stock and what the dose is. I'm going to move forward. Tim, I don't know. You said something about converting a positive pressure cath lab to a negative pressure one. That's an environmental engineer topic, but I may try to research that. I would love to be in a negative pressure environment if possible. So let me talk to my environment.
Yeah, so you don't want my engineering knowledge on the phone. But what I will tell you is that hopefully your hospital has someone who can do it. And there are a couple key things I would say that in the cath lab that are important things to consider. Number one, minimize the number of patients that are in the room. And I think that's an important one. Number two, if patients you think are going to need to be intubated, try to do the intubation prior to coming to the cath lab. It's a much safer situation if the patient is already intubated. Number three, designate one cath lab as the COVID cath lab if you're going to have patients that go there. And I think in that room, then minimize the number of things that need to be cleaned. So like if you can take that as much as possible out of that room and have carts for your PCI equipment, for example. There's lots of labs that have done really innovative things to address this. You know, all of this, of course, depends on what the prevalence of your disease is and where you're at. Hopefully you all, I think most of the sites in this region are relatively low. Hopefully you all stay that way. But I think those are things are really some key things to be thinking about and planning about. It's also, I think, another important one is from healthcare workers. I think age is an important one, and I think limiting exposure for the healthcare workers that are over 60 or are over 65 or 70, I think is a really important issue. And, you know, this might apply to many interventional cardiologists, actually. And I think it's at least something that, that all sites should be actually thinking about, is because there definitely is strong age-related risks. And there's also probably related to viral load, so that's why PPE is so important, that everyone is well-trained on how to use it, and number two, has it available, and that anybody that's actually taking care of COVID-positive patients have appropriate and complete PPE available.
That's outstanding, Tim. I'm going to use one more question for the hospital phase, and we're going to talk a little bit about the post-hospital phase. Your point about, I heard in the prior call from the East Coast about the word, they use the word platooning different teams so you don't have cross-contamination. And I think that's what you're alluding to, as well as some of the people that are higher risk, and if they were to contract it, of not doing well, and trying to limit their exposure. And I kind of think about, if I had a pregnant female, I would not have her exposed to the radiation. I would find a different task for her, but still be able to help the team get the goal, the project or the procedure completed. We have not spent any time talking about non-STEMIs. And as you know, non-STEMIs come in a couple of flavors. Type 1, where we think it's truly due to the acute coronary syndrome process, versus a type 2. We would expect, as Dr. Henry alluded to, that increase of troponin in these types of patients. So we're going to see a lot of elevated troponins, and that will trigger a cardiology, obviously, consultation and head scratching to find out what direction to go. So I'm not going to talk any more about the hospital phase now. I just want to spend some time for the post-hospital phase, and I'm going to throw it out. It's obviously our patients can't have visitors, and therefore even our older patients, and getting instructions and medications and even cardiac rehab. So with that in mind, I'm just going to throw out to the callers, anyone have any ideas or want to share some of the things that have been working in their system for patients to make sure that they know how to take their medicines and get the right follow-up. Personally, I'm becoming more savvy with these different video conferencing tools, and I imagine your hospital is starting to adopt certain ones that have worked well. And I'm hoping that that's going to be something that that maybe this whole experience may transform how we do healthcare in the future as well. So in our facility, I know that we are working towards making sure that we optimize our ability to effectively communicate through some of these tools. Anybody else have any other thoughts, or do they like a particular tool that's been very user-friendly?
This is from the chat box, but Marty says she's doing by phone, following up by phone.
Very good. So,
Bob, can I just say a couple other comments that just came up as you brought? I think the issue about non-STEMI is an important one. And I think what we're recommending is, again, if patients have ischemic symptoms and any high-risk features like hemodynamically unstable or arrhythmias or ongoing chest pain, we are recommend that patient go to the cath lab. And then the second thing is, but if you have just a very small bump, and let's say this is a COVID negative patient, and doing well on medical therapy, then certainly it's reasonable to not take that person to the lab now and to do a risk stratification with the stress test. And then a second thing I will say, there's been a lot of reports of patients with on quote electives, so TAVR, MitraClips, and PCI, that we've been avoiding doing those cases in many cases because of state regulations and to try to preserve PPE. But it's really important that people realize you have to be really thoughtful about that, because what we're seeing now all across the country are increased rise of patients who had their TAVR delayed, had their PCI delayed, and now have had mortality. And so it's really, really important that people be thoughtful and not avoid good care in patients that need it.
Yeah, I think an excellent point, Tim. My focus has been, if I think I can get the patient in and out of the hospital in a very timely fashion, and certainly avoiding the ICU, it's a little more attractive to try to get that done in those who actually need to have something done. So it goes back to what you were saying about the PCI in patients. Preserving PPE, I just want to throw it out there. Some of you may have read that article. It was in the New York Times about 10 days ago about ultraviolet light and reusing masks or some other things. And I think there was a pilot done, but just throw that out there that may be something to try to salvage some of it, because you just don't know how long. I guess the production is ramping up, and it may not be as much of an issue, but sort of throw that out there. If anyone has any experience in their facility or their system, I'd love to hear about your experience and if it's working. Okay.
And a couple more comments in the chat box about follow-up, not related to PPE, but their cardiac rehab team has been calling the patients on the days that they would have normally been in cardiac rehab, trying to get everyone to do an at-home exercise program. And then Susan says that from Fort Worth, she says that they're using MyChart to load the patient's discharge instructions, cardiac rehab instructions. So assuming that must be a portal that patients, if you're able to come off mute, please do so and explain that. But it sounds like it's a portal that patients can access, where they can access their instructions.
Yeah, hi, this is Dr. Singh from Albuquerque again. We have started reprocessing using, I think it's a vaporized hydrogen peroxide for our PPE surgical masks and stuff like that. I think the Duke had kind of recently looked at that as an option, and that seems to be a viable option. So we've started that process to keep those on hand in case we run short on PPE in the next 2 to 3 weeks.
That's reprocessing using, what was that?
I believe it's vaporized hydrogen peroxide.
Okay.
So Lonnie and Bio, this is Tim. I'm going to have to sign off because I have another call at 2 o'clock, but hopefully this was helpful, everyone, and I appreciate y'all being here. Stay safe out there and do your best to take really good care of patients.
Thanks, Jim. I really appreciate your time.
Thank you, Dr. Henry. We are at the top of the hour.
Thanks, Lonnie. You want to wrap it up? That would be great.
Yeah, so thanks again, everyone, for joining us. We will send the slides out to everyone along with the PSAs that you can use. Please reach out if you need anything. We want to support you in any way that we can. And again, just thank you for your time. And thanks again, Dr. Wozniak, for helping facilitate the discussion. Appreciate you.
Great. Everybody, take care. Bye.
Bye now.